So good evening, everyone, and welcome to tonight's broadcast entitled Google Hangouts on Air, a panel discussion on the management of schizophrenia, focus on multi-phase schizophrenia. Tonight is the second of 3 broadcasts in this CME certified educational series. My name is Scott Kober. I am with the Institute for Continuing Healthcare Education, and certainly I want to welcome you as well as welcome our panelists. So tonight's program is provided by the Institute for Continuing Healthcare Education, and we want to thank Genentech for providing an unsolicited educational grant in support of tonight's program. So the learning objectives for tonight's program are to summarize the mechanisms of action for investigational agents used in the treatment of schizophrenia, describe emerging medications that may better control negative symptoms, and compare the effectiveness of various strategies to achieve comprehensive symptom relief, to recognize the early signs and symptoms of schizophrenia, especially those that are non-classic and subtle, and to list interventions that increase rates of aftercare and identify drug side effects that are most bothersome to patients. So there's faculty disclosure information on our Google Plus event page as well as on the Institute website. And tonight's program is streaming live both on Google Plus and through YouTube. An archive recording will be available within a few hours after our conclusion. A link to access the CME post-test and activity evaluation will be available near the conclusion of tonight's broadcast. So before we begin, I want to introduce our faculty. First of all, we have Dr. John Lauriello. Dr. Lauriello is the Chancellor's Chair of Excellence in Psychiatry and Medical Director of the Missouri Psychiatric Center. Dr. Lauriello previously served as Professor and Vice Chair of Psychiatry at the University of New Mexico. He specializes in the diagnosis and treatment of psychotic disorders, most notably schizophrenia. We also have Dr. John Kane, who's Vice President of Behavioral Health Services of Hofstra North Shore Long Island Jewish Health System and Chairman of Psychiatry at the Zucker Hillside Hospital. He is recipient of numerous state and national awards for his research in schizophrenia. Finally, we have Christoph Carell, who was an Associate Professor of Psychiatry and Molecular Medicine at Hofstra North Shore Long Island Jewish School of Medicine, an Adjunct Associate Professor of Psychiatry and Behavioral Sciences at the Albert Einstein College of Medicine, both in New York. He is also the Medical Director of the Recognition and Prevention Program at the Zucker Hillside Hospital in Queens and Director of the Adverse Events Unit and the Core Laboratory Unit at the Zucker Hillside Hospital Advanced Center for Intervention and Services Research. So with that, I will turn this over to Dr. Carell to talk through our first case.
Great. Thanks, Scott, and hi, everybody. So we will be talking today about 3 cases on chronic schizophrenia. And let's go with the first description. So this is a 32-year-old male who works at night in a mailroom, and he lives with his parents. He's brought in for evaluation by his mother, who's concerned about an acute exacerbation of his schizophrenia illness that had been relatively well controlled for the last 2 years. In the emergency room, Robert reports paranoid hallucinations. Paranoid ideations, it should say, and he also has some hallucinations. And the paranoid ideas include the professors that are out to get him. He claims he has 7 senses, including receiving voice messages and faxes via telepathy, and being capable of astral projection, consisting of communications with different people on other continents. Next slide. Scott?
He advanced it.
Oh, sorry. Thanks. Robert admits to not having taken his antipsychotic regularly due to complaints of side effects. He was feeling tired and dull. He started on an oral antipsychotic and then converted to a long-acting injectable since there were some questions about his adherence. His hallucinations that gave rise to his 7 senses, or his perception of 7 senses, and his delusion subsided over the next 2 to 3 weeks, and the patient is discharged home. There he improves further, denying any residual positive symptoms. However, Robert is unable to return to work, refusing to leave the house, and spending most of the day either watching television or lying in bed, sleeping or dozing, or thinking of nothing. So for someone like this, where you have a response to positive symptoms, the patient is on a long-acting injectable, so you have a fairly good idea that the patient gets the medication, but you see that he has impairing residual negative symptoms. What can we do at this point in time? What are the options that we should consider and discuss with patients and family? Should we give an antidepressant? Modafinil, he's also complaining of being somewhat tired. Stimulants, they have been considered sometimes dangerous. Maybe could you increase psychosis this way? Antipsychotic dose reduction, exercise therapy, or CBT. What do you guys think? What would you do in a case like that?
Well, I always want everybody to exercise, so I think exercise is a no-brainer, and it's one of the hardest things we can get our patients to do. But as you know, Christoph, you've talked about this before, exercise is really good for the brain, good for the body. I think this idea of antipsychotic dose reduction really needs to be explored, because sometimes some of this anergia is really secondary to maybe overshooting what is really the needed maintenance dose. And so an idea of judicious dose reduction, careful dose reduction, may make sense for this person to see if they brighten up.
Particularly since we've learned that the continuous delivery with a long-acting injectable might lead to a requirement of lower doses and levels in the blood, so that maybe what we think would be equivalent to the oral dose might not be necessary for the long-acting injectable. Yes.
Right.
Another question that we might ask ourselves, which is not on the list, is are there any specific antipsychotic drugs which are more effective in patients where we think there are residual and impairing negative symptoms? So one might think, for example, that the dopamine partial agonists like aripiprazole or one under development, caripiprazine, might have more of an effect on negative symptoms since they are exerting partial agonism effects as well. And I don't think we've seen any head-to-head comparison suggesting that that particular mechanism of action is more effective in alleviating negative symptoms than some of the other second-generation or atypical antipsychotic drugs. And we should remind ourselves also that these drugs can improve negative symptoms, but often not as much as they improve positive symptoms. And so we're often left with the case like this where we do have residual negative symptoms. Antidepressants might be helpful, particularly if there's a differential diagnostic issue between depression and negative symptoms. And there's some suggestion that even for negative symptoms, antidepressants might be helpful.
You know, in our clinic, I mean, everybody seems to get put on an antidepressant even before we get to them. So I think they tend not to hurt unless we're really talking about some people who can potentially be undiagnosed in terms of switching to some sort of mania, but that's pretty rare. So, you know, I think antidepressants are worth sometimes as a proof of test concept about whether someone's anergia is more of a depression.
Yeah, but we've been talking about also primary versus secondary negative symptoms. So certainly we see some improvement in negative symptoms if somebody had been really withdrawn and anxious because of the paranoid delusions. We can also see that as part of sedation or EPS effects, and clearly those need to be ruled out. But CBT, for example, has not shown to be that effective for negative symptoms. It's maybe helpful for some patients to deal with the hallucinations and how to actually conceptualize them. But to make people enjoy things more or seek out enjoyment and anticipate joy, that's very, very difficult. And I think we definitely have a gap in the current armamentarium. But what are some of the other additional clinical informations you want to obtain in order to see what the best treatment is? We've talked about the differential diagnosis, But what about also then stimulants? I think there has been some work that they might help, and in this case we have at least continuous delivery of the antipsychotic, so we are not as concerned that they might be left with just the stimulant that they might like to take, but take away the antipsychotic. But I think the results have also not been so convincing, correct?
Yeah, I would agree with that. And I think one of the things I would like to know, and we see this a lot, is what are some of his other behaviors and habits. So, sometimes folks who are sort of in this situation smoke a lot of marijuana, for instance, which can make them very amotivational. And so you really want to kind of query that, ideally with the patient, but sometimes they'll tell you, sometimes you just need to check a urine tox, and you might be, not so surprised that they have, THC and marijuana in their urine. And then you start to have to approach that as another problem that the person may have in terms of their sort of negativity.
And we also might want to explore, whether he has any appetitive drives, whether he's capable of experiencing consummatory pleasure, and because we're trying to differentiate negative symptoms from depression, and that would influence our treatment choice.
Right, but also sensory deprivation can lead to secondary negative symptoms. So caregivers might play a role here too, either to differentiate depression from negative symptoms, but also to provide maybe some stimulation. If patients are let out and dragged along, they might actually see a little bit more of their motivation and happiness come back. So I think we need to partner with those caregivers also. And in terms of emergent experimental treatments, I mean, there is obviously the glycine transporter 1 inhibitor, bitopertin, which is under development right now, but also in general, the glutamatergic system has been explored both for cognitive and negative symptoms, and we just hope that some of the treatments that are under development will pan out, which would allow us to have rational polypharmacy and more individualized medicine in psychiatry, where we can add on treatments for negative symptoms where it's needed, and maybe have a different mechanism added on.
Yeah, that raises an interesting point about why we think the NMDA receptor system might be involved in negative symptoms, and the data suggesting that subtherapeutic doses of PCP, phencyclidine, were associated with not just positive symptoms but negative symptoms and cognitive dysfunction. So one of the sort of underpinnings of the NMDA hypothesis, and has led to a lot of interest in developing drugs like what you referenced before, the glycine reuptake inhibitor.
Okay, so I think we have to stay tuned for some of those therapies to come through, but with exercise, stimulation, maybe antidepressants, but dose reduction and finding medications where there's less sedation, those might be initial treatment strategies for this patient.
I do want to mention another approach that can often work for patients like this is some level of peer bridging with other other members with the illness. So their mother telling them to get out of the house or to do things may not work, but if you can get them connected to someone who also has schizophrenia or some related disorder, and they talk about doing things together, maybe going to a clubhouse if that's available, I agree with you completely that you got to get people out of those bedrooms and into sort of to the real world. We didn't talk about even sheltered workshops and employment options that sometimes people can be motivated by the fact that they need a little money. So for whatever today I talked to someone who she really wanted to work because that was the only way she could keep her cable. And so, you go with that and you say, okay, let's keep you working at this workshop so that you can keep your cable, because that was one of the few things that was not provided by, her disability payments.
Right, so the motivational interviewing is so key. What is it in there for them? Yeah, what do patients want? And that needs to be linked to both adherence but also maybe activity levels. Right. I agree.
Infidelity and left home with her kids to live with her parents. She became increasingly agitated in subsequent months, telling her parents that the government was beaming information to her through the internet. The patient was treated with an antipsychotic and a mood stabilizer with good success. After treatment and improvement, her patient returned to live with her husband with no subsequent issues. Her local psychiatrist has been following her and adjusting her medications with some modest reductions. Attempts to go lower were met with a mild return of symptoms. Patient has now requested that she be taken off her medication because she wants to have another child. The husband's unsure what to do, and he tells the psychiatrist he doesn't want to go through what happened to him after the previous pregnancy, although he also wants another child. So one question is, how would you handle Sally's request? And here are some options. I'll read them in case we don't have them up. But let me see. Are we up again?
Yeah.
Scott, with the slides?
Yes.
Okay. So let me I'm going out of mine, so bring the slides up. So how would you handle Sally's request? Guys, what do you think in terms of these options?
Well, as we discussed before, I think shared decision-making is important, and first of all, acknowledging the wish to have another baby, which is a very human right, and then also the fear that you don't want to harm the baby. And I think we need to educate both Sally and her husband that one of the most important parts of having a healthy child and raising a healthy child is having a healthy mother. And so that the lack of relapse or the maintenance treatment is really crucial. We acknowledge that medications can have an effect on the growing fetus, but we should also discuss that the data that would indicate that there are clear damages to the baby are very slim. It's just the other way around. We don't have enough good data to suggest that there is no risk whatsoever. We are clear that most studies have not included pregnant women, but we have two medications, two antipsychotics actually, that are labeled a little different, where there is less of a concern based on the toxicology data and the data in rats and animals, and that is one clozapine, and the other one would be lurazidone, a newer agent, so that these would be options if the patient and her husband were really, really concerned. But on the other hand, if the patient is doing pretty well on the current treatment, the risk for the fetus and for the baby is really very, very low compared to just the basic background risk. So we need to, I think, tell this information and then have a discourse with the couple.
You know, I think in this case what we know is when the psychiatrist had tried to reduce the dose, symptoms were returning. So because we have some cases where patients can have their doses reduced and even maybe tapered off completely, and they may go for a very long period of time without recurrence of symptoms. But unfortunately, in this case, you have a suspicion that if you try lowering the dose, which I think is a logical thing to think of, symptoms will return. And then the question becomes, okay, how significant are those symptoms, and how dangerous are those symptoms to the person, to their fetus, to their family, to everything. So there's a lot of calculations that have to be done. You know, I think it's true that clozapine and lurazidone have, you know, more of a class B warning, but, you know, I don't know if that's something I would necessarily hang my hat on. I wouldn't give this lady clozapine because she's not really a treatment-resistant patient. She's responded beautifully to antipsychotics. And lurazidone hopefully will stay with a, you know, category B, but who knows as it gets used more whether that might change. What do you think, John, about the difference between stopping the medication as soon as she's ready to conceive versus stopping the medicine as soon as she gets pregnant?
Yeah, I don't think we have much data to inform, you know, that decision, and I think that the exposure during the first trimester is probably our biggest concern. But these are tough issues, and I think this is where shared decision making is very important. We've got to present to the patient and the spouse, you know, what we know about risk, and then they have to be part of this decision making process. And you know, as was emphasized before, the risk of relapse and all that entails in terms of you know, the pregnancy and the woman's health, etc. That's a very serious issue. And you know, as you said, these drugs have not been associated with serious teratogenicity. So you know, it's certainly possible to continue them.
Yeah, I would just say that, you know, lots of times people come into our office already pregnant, and so they may already be 2 or 3 months along, and then we're the ones who say, oh, you haven't had your period, and that's kind of unusual for you. Let's get a pregnancy test, and lo and behold, they're pregnant, and they've already been exposed in part of that first trimester. The problem I see with having them stopping the antipsychotics so that they can conceive is that conception could take a long time. It really can vary, and sometimes you could be out there pretty long before anything happens with the chances of relapse. So it's as John said, it's really tough. Do you think, we talked a little bit about the differences in antipsychotics. How do antipsychotics compare, say, to some of the other agents that people try to use while they're pregnant, say benzodiazepines, mood stabilizers? How is that class in comparison? Christoph?
Yeah, I think the risk for valproic acid and benzodiazepines of neural troop defects is much clearer, and one should stop these medications because there are replacements. Other medications can be used in that case. With lithium, we've had a turnaround. I mean, if you look at textbooks maybe 10 years ago, one would say, well, there is a potential problem with cardiac malformation, so you might want to stop. But now more modern data have suggested that the background noise is similar, and if somebody has really responded beautifully to lithium, that would be more in a bipolar or schizoaffective disorder patient. Most likely, we would currently not advise to stop lithium just for the sake of the fetus. Other decision points would have to come in there. But clearly, as you suggest, like valproic acid and benzos are basically a no-no.
And
I would stop them before trying even becoming pregnant.
But the lithium history that you shared, I think, also emphasizes how difficult it can be to gather enough data to be certain as to what the risks are. And certainly, I remember, years ago when the Epstein malformation was a huge issue in the use of lithium. So, again, we need more and more data to inform these decisions.
Yeah, and I think the risk of not honoring Sally's request is that Sally will just not show up again, and that's often how they'll vote. But I do think engaging her husband, I mean, in some respect, the family, both she and her husband, their assessment of the risk-benefit has to be determined, and all you can do is give the best information you can, and they will decide about taking the risk or not.
And if they do take the risk of stopping the medication, obviously psychoeducation is key to let them know what the warning signs are and not come back too late, but rather restart the antipsychotic before the full relapse has emerged, but letting them also know that this targeted intervention might miss the boat and we might treat too late.
Right, and paradoxically, patients think, oh, I'm off my medication, I don't have to see my doctor at all, and it's the opposite. You really need to see your doctor a lot, because we really want to monitor you closely if you've decided to come off the medication to catch relapses and tolerate some relapses. I really think that's an important distinction. A patient who has symptoms doesn't necessarily have to be treated through their pregnancy if those symptoms are containable. But if they're suicidal, or if they're homicidal thoughts, or if there's any sense that the person is unable to take care of her other 2 kids, then you have to intervene. So it's really close monitoring, shared governance with the family, talking to them a lot. It's a challenge, but it's something that we have to take on when we have patients who are of sort of the age to still have children.
And also, it's a positive. Many patients with schizophrenia are having difficulty with social relationships. So, we have someone here who's trying to have a family, and in many ways, that's a very healthy thing.
Absolutely. Okay, should we go to the next case?
So case number 3, we're talking about preparing for outpatient treatment, and this patient is a 46-year-old recently discharged from jail after his 4th trespassing and loitering arrest. Information is sketchy, but the patient has apparently been living in the same city for 10 years and has family out east. Manuel's judge has released him through a mental health court order to come for treatment at the local community mental health center. The patient is assigned a case manager and is living in a transitional housing apartment. He's a pleasant and relatively passive individual. His prior history indicates that he takes medication willingly in the hospital, but not during outpatient care. There's also some concern that he will use illicit drugs when available after leaving transitional housing. He started out on oral antipsychotics while in jail and has responded well, becoming more organized and better able to care for himself. So the decision point, what treatments would we choose? Mandated 12-step substance abuse program, continue the oral antipsychotic that he responded to while he was in jail, add an antidepressant, transition manual to a long-acting antipsychotic, and CBT. Well, I think the major focus is really on the information that we got that he has trouble taking oral medicine when he leaves the hospital. So I would think that considering a transition to a long-acting injectable could be very valuable. Now this is a tricky area because if you look at the literature, it can be very confusing. In recent years, we've seen some controlled trials comparing long-acting injectable drugs to oral medicines that don't necessarily show a consistent advantage for the long-acting drugs in terms of preventing relapse and rehospitalization. On the other hand, we've seen some mirror image studies which do suggest an advantage for long-acting injectable drug, but mirror image studies are not necessarily considered at the same level of evidence as are randomized controlled trials. The problem, though, when we sort of kind of get into this, is that the randomized controlled trials may actually underestimate the potential advantages for a long-acting drug because they are research projects that require consent and that also usually involve a lot more attention and a lot more help with getting medication, reminders to keep appointments, research assessments, monitoring psychopathology, side effects, et cetera, et cetera. So it's not really real-world treatment. And it may be that when we use long-acting injectable drugs in the real world and not in the context of a randomized controlled trial, that their impact is actually greater. But this is an area that I think is confusing to many people. My personal opinion is that for a patient like this, considering the use of a long-acting drug is very important, then the next step, of course, becomes getting the patient to agree to that concept. And I think that is a challenge for the Therapeutic Alliance, for psychoeducation, for shared decision making, for motivational interviewing, et cetera, et cetera. Some of the other possibilities that were listed here, a substance abuse program. Well, that'll depend on what the nature of the substance abuse has been, how serious it is, but certainly it is important to provide a treatment for substance abuse, and I think there are many settings in the United States right now where substance abuse treatment and psychiatric treatment are sort of separated. They're in different silos, and for a patient like this, they need to be really integrated. Adding an antidepressant, as we discussed earlier with one of the other cases, it's certainly understandable to consider a therapeutic trial if we think that someone is depressed. One could argue that if we're uncertain that perhaps there's nothing to lose in trying an antidepressant, as long as the patient is also taking an antipsychotic drug, and that's another reason to emphasize the use of a long-acting drug. We'd be more uncomfortable with a patient given an antidepressant if we weren't confident that they're actually taking their antipsychotic as well. And CBT, I think CBT can be a very helpful treatment for patients with schizophrenia. Unfortunately, it's not always available. And we would like to see it more readily available in community clinics around the country. It has been shown to be helpful for many aspects of schizophrenia. But what do you guys think?
Well, I think I certainly think a long-acting agent would be a good option for him because he's described as engageable but so passive that maybe his passivity keeps him from kind of consistently taking his medicines. And so one could engage him and say, this will make your life a lot simpler. It won't necessarily, data is still not there to say, okay, this is going to absolutely reduce your chances of relapse, reduce your violent episodes, be a perfect medication in terms of side effects, because some of the side effects, like weight gain and some of the non-dose related side effects, are just the same as they are for the oral. Some side effects, like some of the dose related, like EPS side effects, tend to be a little bit better with the long-acting agent. So I think I think the long-acting agent really helps you determine whether the patient is currently adherent to his treatment. Because when he doesn't show up for the next injectable, you know, okay, he's declared, I'm not really going, to follow the treatment plan as we've discussed. And then there's a whole potential mechanism of getting case management, or in his case, maybe his probation officer, to work with him to come back and come and get the next injection. So, you don't get that with the orals. Unfortunately, with the orals, what you get is patients saying they're taking it, and you just can only hope that they're taking it on a consistent basis.
Right, and I would also try to discuss with the patient, well, most likely you didn't like being in jail, and maybe some of the reasons for being in jail had to do with your mental illness. And while taking drugs might feel better than taking medication, having the medications on board as a basis will be much more likely to keep you out of the hospital. And in a patient like that who has shown relapse and who has substance abuse, who is an enriched person for relapse risk, a long-acting injectable most likely will show a benefit. And I mean, what you say, John Lauriello, about the side effects, sure, we have to tell them that most likely not everything will be easier than with an oral medication, but except for olanzapine and the post-injection sedation, somnolence syndrome, usually side effects are not necessarily higher. If anything, they're similar or they are better.
Right.
They don't have to remember this. Also, there's less of an issue with other people always breathing over his shoulder whether he is taking the medication. So I do agree that this might be a very good choice to easing the transition into outpatient care and ultimately increasing autonomy. There's this false belief that offering people a long-acting injectable removes autonomy. It actually, when patients agree and maybe talk to peer counselors, they can realize that it increases their range of freedom.
Absolutely, and there are so many other areas in which we can try to help patients achieve autonomy. I think we shouldn't risk non-adherence and subsequent relapse. And in the case of this gentleman, if he ends up in jail because he's trespassing or commits a misdemeanor, and this highlights one of the problems that we have in this country right now, that we have many mentally ill people who unfortunately end up in the criminal justice system, which does not do anybody any good. And we have to really work very hard to figure out how to do better in keeping these people out of the criminal justice system. So in terms of just some other discussion points, what other clinical information would we want to obtain? Whom might we contact? We heard that this patient's family is not involved. They don't live in the same geographic area. We certainly would want to be in touch with the parole officer, the people who treated him in jail, understand what they saw, and we do need more history. We had a very cursory review of substance abuse and issues of passivity, et cetera, et cetera. We want to learn more about his mood, his motivation, what his goals are, et cetera. We certainly talked about the impact of non-adherence, and we spent a lot of time discussing the potential value of the long-acting injectable drug. In terms of distinguishing passivity, depression, negative symptoms, avoidant delusions, we've talked about this a little bit. I mean, you need to ask more clinical questions. This is an area where the clinical interview is very important. It's nice if you have informants as well. In this case, we may not, but we want to get a sense of from him as to whether he enjoys anything, what motivation does he have, what kinds of pleasure does he anticipate, et cetera, et cetera. The use of illicit drugs, of course, is a concern in people with psychosis, and that substance use may be a contributing factor both to non-adherence and also to relapse. So he has to be educated that in his case, because of the illness that he has, Even drugs like marijuana may have a deleterious effect, and that he needs to be aware that this could potentially interfere with his long-term goals, even though it may seem reinforcing in the short term. And then, as we said, long-acting antipsychotic drugs are not a cure-all, and that we have to use them judiciously, but they can play a very important role in some patients. And as John Lauriello emphasized, just informing the clinical team as to whether or not the patient is actually getting the medicine is very, very important. That's critical knowledge for us to have, because it can lead to intervention strategies that ultimately will be very helpful. We also have medicines now that can be given once a month, and for a patient to get 12 injections a year might actually be much less of a challenge than taking oral tablets every single day, day in and day out, 365 days a year. So, I think patients need to understand the options that they have when we talk about different formulations, different treatments.
Yeah, I will say something, about the illicit drug issue. I mean, I think we all know that, that's always going to make things a bit worse. In the short term, they might feel better, but in the long term, whether they're drinking or drugging, it's going to be a problem. The idea of using a semi-confrontational 12-step model that demands sobriety probably won't work for a lot of people, especially people with psychotic illnesses. And so I think in my opinion, the best approach is a very harm reduction model where one has to tolerate some use with the constant idea of replacing that use with higher levels of functioning options, like going to day programs, reconnecting with your family. There's still a chance this guy's family is wondering where he is, and so maybe trying to work with him to get an address and try to nowadays you can track down people. Trying to track down his family might not be the worst thing. It could really be helpful to him. So really this idea of harm reduction, using motivational interviewing for every kind of intervention works actually pretty well, but trying to work with them to say, well, I know you like to smoke pot, but what does it do to you that you're not crazy about? What's the things that are making your life a lot harder when you smoke? And let them come up with the reasons why it sometimes interferes with their life.
Yeah, absolutely. Those are very good points.
Okay. I think that kind of concludes our broadcast tonight. I thank the three of you for adjusting on the fly as I kind of got kicked out, and you guys kind of continued on without me. So hopefully things went pretty smoothly from a learner's perspective. So as I mentioned at the inception of this broadcast, there is a link that has been put on our Google event page, and it'll also be included on YouTube for physicians who are interested in earning CME credits and taking the post-test and completing the evaluation for today's broadcast. And we do have one more broadcast in this series. Our third and final broadcast, which is going to focus on treatment-resistant and refractory schizophrenia, is a little less than 2 weeks away. It's going to be Monday, November 4th, and this one's going to be a little earlier in the day, so it's going to be at 3:30 Eastern Time. So we'll have a whole new cadre of cases to discuss at that time. So with that, I'm going to wrap up our broadcast, and thanks to Dr. Corral and Dr. Kane and Dr. Lauriello once again, and we will hopefully see everyone in a couple weeks. Good night, everybody.
Good night.
Good night. Thank you.
Thanks.